Thank you, Sriram. Thank you, Nirmal, Murli, and all the members of the Tamil Nadu Ophthalmic Association for giving this wonderful opportunity, all the delegates who are gathered here. I think it's very important and appropriate that I am following this topic after Nirmal because he has talked about what are the quality assurances which are very, very necessary, or key performance indicators which are very necessary. Let's see what we are missing as far as 2020. We are able to get this 6/6 vision for all these patients nowadays. It's not a big deal, but something else is happening. The sun is setting on the old mindset of cataract surgery. The old mindset is we have typically a very dense cataract, old patient, 80 plus, coming into your clinic with 3/60 or 6/60 vision. So this is the golden triangle: premium IOLs, premium surgeon, and the premium surgery. And we need to make sure that you consistently hit the bullseye. The new mindset is very, 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 very important. That is, new mindset is like a luxury consumer. It's like a plastic surgery patient. He's coming with 6/9, 6/6 vision. You're not able to drive at night. He's got decrease in the contrast sensitivity, quality of vision, and all these problems can occur. And these patients, their expectations are also going up. So how many of you had these patients like this? 6/6, 20/20 patients, they're unhappy. They take the life out of you. Am I right or not? Okay. Can I have a show of hands? How many of you? I'm sure many of you. If you have not seen it, you will see it in the future. Because this is one of the major problems, changing profile of the cataract patient. And they are hugely aware. They are the expectations are very huge. They are highly demanding lifestyle changes. They think they know everything. I'll just give you two examples. Music master Rajan. Okay, you know about him. And yes, Indian cricketer Kapil Dev, everybody knows about him. I operated Rajan in 2007. At that time, we put Restore Plus 4 lens for him. And Kapil Dev was operated in Delhi. He was also, both of them, Restore Plus 4D. Okay. What is this thing? At that time, only multifocal was available. Okay. So this is a bifocal lens. So now Raja is finding it difficult to use the keyboard or the harmonium, okay, because that is the intermediate distance for him. And Kapil Dev is now playing a lot of golf. He is now having difficulty in putting. So what is the problem? The multifocals these are bifocal lenses. These bifocal lenses means they work for distance and they work for 33 or 35 centimeters. Intermediate is not there. The range of vision is not there. So what is this multifocal or bifocal lenses meant for housewives, house husbands, and mother-in-laws? Okay. And these are new generation IOLs which are coming. So all these new generation, the EDOF lenses, the good intermediate vision they are able to give. Because the new this thing is, for example, where I am using my laptop, where I am using my iPhone, okay, your phone, it's about 60 centimeters, 50 to 60 centimeters from the eye. Reading a newspaper in 2010, guy is reading a newspaper because he is reading a hard copy of the newspaper. Okay, that's 35 centimeters. Reading a newspaper in 2022, he is reading a newspaper not on the newspaper. He is reading a newspaper on the tab, on the iPad. So automatically the distance goes. So the near point has actually receded from 35 centimeters to 60 centimeters. If you take the newspaper sales of Chennai, okay, in Hindu and Times of India, everything has gone down. Because people are now reading newspapers not on the newspaper hard copy, but they are reading on the, so the intermediate vision, we call it the new middle. So this is a refractive multifocal. I'm going to take you quickly through some case scenarios. Refractive multifocal, vision 6/5. I operated this patient way back in 2003-4, I think. The rezoom lenses, I don't know how many of you are aware of these lenses. Rezoom lenses, at that time it was made by a company called AMO, subsequently became J&J. And these are refractive multifocal lenses. Very good lens. Only problem is you can see the rexis is as good as the femto rexis. 6/5 N6, patient not happy. Why? Because the halos, the photic phenomenon. Okay, halos around the starbursts, around the headlight, and significant glare. Okay. And this patient actually was she was a type C personality, but once she started seeing the halos and glare, she became a type A personality. Okay. And this is the problem. When you have glare, it can be very bothersome if somebody can see this refractive multifocal. Of course, with newer trifocal lenses, it's much less. This patient sued me. Okay, at that time I got really scared. Fortunately for me, she died of myocardial infarction 6 months later. So I'm telling this is again another patient, 55-year-old female, EDOF lenses. Okay, EDOF lens 6/9 N6 vision. Patient not happy. Problem. What is the problem? The problem is, okay, can you see something there on the lens? Right in the ask your assistant not to hold the optic of the lens with any forceps or anything, whether it's a unifocal or a multifocal. Okay, I thought it's just a scratch on the lens and left it like that. I should have actually removed, but there is a crack on the lens. Okay, this patient went to another person in Meta City, Chennai City, and that fellow said, you got two cracks. One is a crack on the lens, another is a crack as a surgeon who operated on you. So this patient also became very furious. So this again very very important. Okay, especially multifocal restored lens. Complaints of misty vision. So this is a problem with this Acrisoft IQ platform. Hope the Alcon guys are not here. When they have glistenings on the lens, glistenings are subsurface nano glistenings. These glistenings on a monofocal lens it may not affect, but on a multifocal lens already the contrast is reduced by to 25%. On top of that, glistenings can affect significantly. So again, a 62 female patient, 66N6 patient complains of decrease in the contrast, and you can see the slit lamp. You can see here there are only lines on the posterior capsule. There is only a wrinkle on the posterior capsule. Okay, you don't have to wait for the posterior capsule opacification. In a monofocal lens, in a multifocal lens, even a line or a wrinkle on the posterior capsule can significantly drop the visual quality and contrast vision for these patients. Okay, so we need to yak them much earlier than normal. You can see just a line or a wrinkle on the posterior capsule, and you can see here how it is, the wrinkles which are there, and once you yak them, the patient becomes all right. Again, you can see another patient not happy. What is the thing? You see the fundus is normal, 6-6 vision. Patient typically tells you, okay, that immediately after the surgery I was able to see well. Past 1 or 2 days I am not able to see well. After a couple of weeks, okay, if you see the anterior segment, everything fundus normal. But if you do OCT, okay, how many of you have do OCT for all these patients pre-operatively and post-operatively as well? Please put your money on OCT. Put your money on a good optical biometer, put your money on a good operation microscope. These three things. Don't buy Mercedes or Audi. Okay, buy all these three things are very, very important. The OCT picked up the CME and the patient became all right once you put the patient onto steroids and non-steroidal anti-inflammatory. Again, a patient with right eye, left eye, you can see here multifocal thickness, residual astigmatism. Okay, you can't have residual astigmatism. Nowadays we have every formula, every patient, you take the IOL biasing and you feed it in the Barrett toric calculator. Any which is against the rule of astigmatism. Anything even about 0.75, 0.8 against the rule of astigmatism. Against the rule means the horizontal meridian is steeper than the vertical meridian. If you take 100 people in the population, 85 to 90% will have against the rule of astigmatism. You need to overcorrect them. So go for a toric lens for these patients. So obviously we didn't go for a toric lens, the patient became unhappy. You can see another patient, can see a Technis multifocal lens, perfectly done surgery, no problem at all, 24.5 diopter. You can see what's happening, post-operative refraction. Okay, plus 2.5 in the right eye, plus 2 in the left eye, post-operative refraction. Okay, if you make them myopic, they will only cut your head. If you make them hyperopic, they will cut and bury you. Simply I will tell you, because if you make them hyperopic, the problem is, if you make them hypermetropic, they are not able to see distance, they are not able to see near, they are not able to see intermediate also. Okay, they become very unhappy, and this patient also became very easy. But what is the reason for this? Dense asteroid hyalosis. This patient, I did an OCT, I do OCT for all my patients. I do OCT was perfectly normal. You can say dense asteroid hyalosis in both eyes. The dense asteroid hyalosis causes alters this refractive index of the eye. So I discussed with Samuel Mascott and Warren Hill and Bobby Osher, everybody. We didn't know because what is happening. You can see this is a problem. So when you have dense asteroidosis, probably you have to be a little more careful about the thing and not probably put a multifocal lens for these patients. Again, you can see crystal lens, quickly go through it because the crystal lens is an accommodating lens. I used to use a lot of lenses way back in 2009, 10, 11, and suddenly this lens can move forward, and it's called the Z syndrome. And this is again a patient with a capsular phimosis. When you have capsular phimosis, the lens can move back. When the lens moves forward, there can be a myopic shift of the eye, of the refraction, and when the lens moves backward, there can be a hyperopic shift. So once you do a capsulotomy, YAG laser capsulotomy, again ocular surface is something which we neglect. Okay, straight away when a patient comes, you straight away take the slit lamp and look for any cataract, but look at the ocular surface, look at the lid margin disease, optimize the ocular surface. before you deal with these patients. Maybe lubricants and ointments for this MGD, because MGD is not only for the unhappy patient, but also MGD is high risk for lid margin, high risk for endophthalmitis as well. You have to be very, very careful about it. So, because a lot of organisms can be there in the lid margin, which can go into the anterior chamber during the surgery, and this can happen. Again, symphony lens, patient, she's a gynecologist, very happy, 6'5" and 6. And first time she told me, a gynecologist, she is able to differentiate between ureter and uterus. Okay, normally they get confused. When they do a hysterectomy, they take the ureter also, but she is very happy. But what is the problem? This is the negative dysphotopsia. Negative dysphotopsia is because of the anterior the retina, which is on the nasal side, getting reflected into the temporal space. We do not know, many people do not know why it's occurring. It occurs only if there is a perfectly done surgery. So negative dysphotopsia is very, very difficult to treat. And what we do is, sometimes we can ask the patient to wait for 3 months, 6 months, or after 6 months, what to do? We give them some other problem. Okay, so that they'll forget about this negative dysphotopsia. So something which is functional also. So quickly I'm going through this, and both eyes cataract surgery done within 1 month, and I think I overshot the time. Yeah, we can take another. Okay, yeah. This again, you can see a PSC cataract, steroid-induced cataract, and Meenakshi has come. She can give a talk, and you can see this. So, what is the problem? The synergy lens I put 6'6" and 6. Patient not happy. Why? Not happy. You can see fundus is normal pre-operatively. I forgot to do a OCT for this patient. You can see what is this? Vitreomacular traction. And that is why I'm telling, do a OCT. Do a OCT. OCT, put your money on OCT is perfect. Because sometimes in a dense cataract, you'll not be able to see the macula properly. You can miss subtle ERMs and OCT and all on the macular holes and all these things. So all these things I think is very, very important. Look at the angle alpha. Quickly I'm going through since Meenakshi has come. And again, you can see this is one of my associates who left a lens which has got only one haptic. Okay, you can obviously leave like this. Okay, and we had to go in and explant this lens, cut this lens and take it out and put another multifocal. Okay, so you can just see on the table, you decide what to do and how to handle. One thing which I want to tell you is, when a patient is unhappy, always look for residual refractive error, PCO, CME, do a OCT. Clinically, you may not be able to see that CME. Dry eye, ocular surface, decreased contrast, look for glistenings, higher order aberrations on the cornea, lens tilt, decentration, functional overlay also. When you have a patient who is unhappy, always look for and tell your staff, tell your security person to bring the patient straight away into your chamber. Okay? And make sure that you finish off that patient within a few minutes and escort the patient straight away out. Okay? Because if he's going to sit there in front of among the other patients in the OP, he will screw up the other patients as well. Am I right or not? Okay? So this is a message I wanted to give you. Thank you again for the wonderful opportunity, the patient attention, and any questions from the audience I would like to take.
Thank you. Thank you so much, sir. Especially the last 2 lines of advice is very well taken.
Yeah.
Just had one doubt. What is your cutoff for against astigmatism for multifocals?
Anything above 0.75,
yeah, because
I do.
Sometimes with the online Barrett, it suggests a toric even for 0.4,
0.4. Yeah, that's what I'm telling you. You need to put all your formulas in your Barrett toric calculator. And against the rule, it will tell you even 0.3, 0.4, it will tell you go for a T1, a T2 lens or something like that.
But would you do that? That is my question.
I will do that. 100% okay. I will do. 100% I will do. What do you mean?
Yeah. So some questions?
Yeah. No, I think Dr. Meenakshi has come.
Yeah, okay.
You want to ask any question?
Okay. So till Dr. Meenakshi sets up her presentation, Mohan sir, how do you select the brand for the VIP patients? Because most of them, they do a thorough study and come.
Yeah.
And when we tell one type of lens, they'll confront or ask for a different, or they would have asked for second opinion and they suggest those.
No, I do a math. I do the counseling myself. I don't leave it to the counselors. I do a math myself and find out exactly, because the chat time is something which is very important. Do everything pre-operatively. Don't do anything post-operatively. Pre-operatively, you have to spend a lot of time with the patients. What exactly is the visual requirement of the patient? where the patient is just wanting vision for distance and reading, and I will go for a trifocal. If the patient say, no, I'm doing a lot of driving, then push them to EDOF lenses. So like that. If the patient says, no, I don't want even anything, I don't mind occasional glasses for reading, then I go in for the enhanced monofocal lenses. So like that, I broadly divide them, but it's important that you talk to them personally, because unless you talk to them, because the patient is going to relate to you, he's not going to relate to the counselor post-operatively as well.
And if you think somebody has got very high expectations, would you dissuade them from a higher end lens? Somebody who's very demanding, and because you have that sense that they are going to create an issue later.
Absolutely. I think it's a very important, the type A personalities, you need to make sure how important they are, and you have to tell them what is the realistic expectation. You can't obviously expect them to read a trifocal lens with a candlelight dinner, whatever it is. They cannot be, able to, or any stock market, this thing. It's not possible. You have to tell them what is realistic from the surgery. I think realistic expectation is something which is very, very important, and tell them. Okay.
Yeah. One more thing is, many of them come with comorbidities, particularly ERM or diabetic macular. Very difficult to satisfy their post-operative requirement.
Yeah.
So when you tell them, how do you really desist from, because they are prepared for a trifocal, whatever the cost.
No, I think you have to tell them. You have to be very clear. You have got a posterior segment problem. There's absolute contraindication for your trifocal lens. Yeah. Tell them. Yes.
Yes.
So they have recentered ablation. So all these things, I think these are patients whom we should explore.
Yeah, because I didn't have time. Because
I have a lot of these
all the refractive surgery patients
do
a topography to find out whether the center ablation, or do an eye trace to find out whether any higher abrasions are there in the cornea. So all these are very, very important. So I think we are running out of time.
Yeah.